talking about collaboration. Our next presenter is Dr. Andrew Knight from the Fairfield GP Unit, who will talk about a collaborative project between GPs and the Southwestern Sydney Local Health District Cancer Services. Please welcome Dr. Andrew Knight.
Hi everyone, I am a GP. I've been a GP for 25 years. I'd love to talk to you, but unfortunately I'm very busy and I've got to go, so perhaps you could ring our receptionist and see if you can get in. So I've been a GP in Katoomba mainly for the last 15 years and for the last 3 years at the Fairfield GP Unit. Just a little ad, if you're interested in the implementation arms, you might consider the Australian Primary Care Collaborative that I've worked with for the last 10 years, which has worked with over 1,800 general practices and has a great way of implementing stuff with them. And the other thing is I'm on the board of MPS Medicine Wise, which visits most GPs every year to talk to them about evidence-based practice. And that might be another way to get in the door. Oh, what did I do wrong? I went the wrong way. There we go. This is a project which is a relationship, and I think what Jerry was saying this morning, that relationships work in improvement. The great thing about this project is the players, I think, that we've got the GP unit, which is an academic general practice within Fairfield Hospital. We've got cancer services led by Jeff Delaney in this case, and Jeff has been an inspirational leader in setting a culture and a DNA from the top that is keen on improvement and keen on integration. The Ingham Institute, which is a research institute in southwest Sydney, and Afa Gurgis has been also inspirational in being willing to be involved and to work on implementation in our region. And of course a major player is the Primary Healthcare Support Organisation, the Medicare Local for our region. And we've just heard that the boundaries are going to be the same as they were. So the LHD and the Medicare Local, or the Primary Healthcare Network as will presumably be able to continue to work together. And the catalyst for this relationship has been a little bit of money from the Cancer Institute, which has enabled us to work together and do a couple of projects. So I think that is a great example of the way you can work towards seamless cancer care if you have the right players around the table and a little bit of resourcing. So we got funding for a couple of projects, and I presented the first one last year. We actually talked to 22 GPs and carried out semi-structured interviews with them. I think it probably does help being a GP unit trying to drive this, because you do understand the culture. We also had a delightful, polite, persistent research assistant who pestered people until they'd talk to her. And this was a very rich source of data. And in summary, a few points which came out was that basically the GPs were very happy with the cancer services in our region. And that was really encouraging to the cancer services, because they've been working hard on the service they provide. They didn't necessarily know what was going on. They didn't sometimes feel like they had a relationship. They didn't know the people who worked there or the services that were provided. The same problem you had in Broken Hill. People turn over. One GP said, I'm new, I've only been here 3 years. So it's understandable that I don't know what's going on. You think, 3 years? How long does it take to find out what's going on? She'd been somewhere else for 20 years and she just knew it like the back of her hand. But when you've been there 3 years, you're only just beginning to understand the services in the region as a GP. The other thing they said, and the main thing they said, was patient care letters are not timely. Tim found that efficient transfer of information was the most significant priority. So I'm glad we worked on that. So we decided to speed up the letters. We wanted to produce them more quickly, wanted to transmit them better, and the Cancer Institute was kind enough to see that as an important project and fund us to continue our relationship, building our relationship and our work together to work on that. So if you've done any quality improvement and you know the model from improvement that's commonly used, there's 3 fundamental improvement questions. You ask yourself, first of all, what are we trying to achieve? And you don't move on until you've worked that out. It sometimes takes a long time to work it out. Our answer was, letters in the hands of the GP in a week, from cancer services to the GP in a week. It's pretty clear, pretty simple. How will we know the changes in improvement? Well, fortunately, there's a wonderful IT system that the cancer services use called Mosaic. I never know how to spell it. Does it have a Q or a C? Okay, well, Mosaic refers to Moses, which is, the font of wisdom, but Mosaic's probably even better. And we decided to use the measures in Mosaic, which was the measure from dictation to approval of the letters, and that was going to be our improvement measure. It's not ideal, because you've actually got to take the letter and put it in an envelope, and that takes time too, but we're working on that to extend it. We've actually altered the way we collect data, and we're hoping to use from the moment of dictation to the moment of transmission of the letter to be our improvement measure. And then we start to think, well, what changes do we think will make a difference? Those are the three simple questions you always ask yourself if you're using that model for improvement. What are we trying to achieve? How will we measure it? Okay, now we start to think, what changes can we make? And everywhere I've worked, people usually make the changes and don't measure and are not quite sure what they're trying to achieve. So doing it that way is a good way around. And then we used a couple of tools, which is process mapping, and then we got a little team together to do rapid improvement cycles. So that's the aim. Letters within a week. How did we arrive at that? We actually did survey our GPs. We sent out a small survey with treatment summaries and asked them, how long did this take for you to get this letter, and did you think it was timely? And there's some results. You can see down the bottom the number of days. If they got the letter in 7 days, it was all blue. They all thought it was timely. If they got it in more than 40 days, and there were 7 of those in our cohort, none of them thought it was timely, and in between they were mixed. And they're a pretty positive bunch generally. So we decided to aim for 7 days. We were going to try and get those letters in the hands of the GPs in 7 days based on this survey. We got together an expert reference group around the table. Jerry said the same thing. Carrie said the same thing. You need the right people around the table. It's got to be bottom up. So we got a group of people, cancer admin, oncologist, IT people, GP practice manager. I'm a GP. We've got the Medicare Local there. We sat around the table and we processed mapped getting a letter from the point of consultation to the point of transmission. And there is our process map. We're very proud of that. Yes, it does look like a dog's breakfast. But the point of this is not to laugh at our service. I'm sure if you processed your service, it'll look the same. I think the good thing about our service is people were willing to be honest. It was not a punitive environment. People were willing to say, actually, no, that doesn't work. Actually, no, we do this then. And so it turns out to be a process like that. There were 4 different modes of dictation being used. You can see that circle on the left is the consultation. The circle on the right is the GP reads the letter. About 2/3 of the way across was dictation to approval, and then beyond that, on the right-hand side, is the actual transmission. Okay? And there's lots of things to work on from dictation. When are the letters dictated? And we've been into that. Now, are all the letters being dictated for all the different consultations? And then how are they then transcribed? There were 4 different methods being used. There was Dragon, and it was being sent externally, and there were dictation people in-house. And then it had to come back, and then it had to be approved by the people who'd written the letters and altered, and then reapproved, and then there were registrars involved, so it had to be reapproved what they had done. And then they were printed, and then they were folded, and then they were put in an envelope, and then they were sent. Now, it's a small project, isn't it? It's just getting a letter out. But it is considered one of the most significant things you can do, and you can see how complicated it is. Our job was to tidy up that process map. And so what we did was we got a Microteam together, and we've been meeting every 2 weeks since July trying to increase this, and we've got some Microteam members here who worked on it with us. We did rapid improvement cycles, PDSA cycles they're sometimes called. So you just find a little thing, you're going to measure what the change is, and you do it quickly, you come back together, you talk about it again. And we did that over and over again. And we worked on dictation to approval mainly, and there's our numbers. So that top green line is dictation to approval. That's the summary measure, the most important measure. We did the process map somewhere back in March. We didn't actually start meeting until July, where that black line is, and the delay was because, for practical reasons, Cancer Services was moving office. They just didn't have time to think about this project. But they already started making changes based on the process map. And then when we got together and started making other changes, the small team, and I've got to give credit to the admin people, they came up with great ways of testing. For instance, they produced a 4-minute dictation, and they ran it through each of the 4 transcription services. And they costed each one and timed each one. And on the basis of that, we turfed at least 2. and that has speeded things up because we're using the cheapest and the quickest, funnily enough. So we went through that over and over again, and we're continuing to meet. And so we're now down to an average of 5 days between dictation and approval of a letter. And that means that we can get them out pretty much in 7 days because we know we're getting them in the envelopes pretty quickly. Okay, so that's good, and we've had more data. We've had a couple more data points on the run chart, and it's continuing to be at 5 days. And I just want to do an advertisement for run charts. I don't know if you use them, but that's called a run chart. And you can see if you get the measure right, and it's sensitive to the improvements you're making, it's a really easy way to present data. And people can understand it, and they can buy into it, and people can feel good, and they can want to keep it there at 5 days. You can see where we made the biggest difference. It's in the blue line, dictation to transcription. It was those transcription services that were really slowing things down. And fixing that has made a huge difference. But we have also made a difference in the dictation to approval, because there were some bureaucratic processes that we could just find we could take whole steps out and it would speed things up. Once you do that process map, you can see where you can make changes. Okay, so now we're continuing to meet. The project goes till the end of the year, and we're working on a couple of other priorities. One is, part of our project proposal was to make this sustainable and routine. It's one thing to do it in a project, it's another thing to make it part of business as usual. And one way to do that is to use data. So we're now organising a report that will come up every month to the executive of the cancer services, where they will watch dictation to approval. That'll be one of the things that they look at all the times. It's one of the most significant issues, as Tim has found. They're going to keep watching that to make sure it keeps happening. So we're going to document the new process, and we're going to make it a regular part of the KPI dashboard for the institution. Now, Jerry would approve of this one because it's come from the ground up, it's clinically meaningful, it's worth watching, I think. The other priority is actually that right-hand side, the transmission side, and we are looking at digital transmission. And secretly, that was a big part of the reason for doing this project, because I think everyone believes that easy transmission of data between primary and secondary care is key. We have the tools almost there. In August last year, almost every accredited general practice in the country installed digital transmission tools. But almost no GPs in the country are using them because they're just not quite usable yet. So we were delighted to see that eHealth was continued in the budget, and we're using this project to continue to work on this. Currently we use mail, we considered fax and dismissed it, so we're going for digital. That is the agenda, and it is a rapidly evolving environment. Those of you who work in New South Wales Health know that HealthyNet is the buzzword. It's going to connect up Cerner, the Cerner system, with GP systems. So, we are moving towards working on the Cerner system, on the HealthyNet system. So a conversation has begun. By doing this project, we're focusing on it. Why shouldn't cancer services in our region, Southwest Sydney, be the one that first gets HealthyNet working and gets digital transmission of consultation letters to GPs happening in our region through the HealthyNet process? Why shouldn't it be? Well, we've solved the produce the letter thing, so now we're moving on, and there's pressure to move on to the other things. So there's lots of stuff about the strategy. There's different methods you can do it to get digital communications to GPs, but we're going to go, I think, and focus on HealthyNet is the way we're working. So in conclusion, general practice and cancer services must work together. I think we've seen that come out over and over again in the conversation, what Jerry said, what various people have said today. It's a priority, and it's great that the Cancer Institute is working on that, and we've been really pleased to be part of that and to have Southwest Sydney support that. It requires partnerships between all the groups, and these projects, working around an actual project is a great way to have a partnership. It's one thing to go and talk to people and say, let's have a partnership, let's work together, absolutely, let's sign the document, but then what do we do? Much easier to have a job that's worthwhile and build the relationships around that job. Timely communication is necessary. I was fascinated to see Jane's study, Tim's study, so many people saying communication across the sectors is crucial, and we're glad to be working on that. And I guess it's possible to improve, is what we're demonstrating. You can speed it up. And quality improvement is a clear paradigm and useful tool to work on this process. Thanks very much.